Hello, good day everyone. It's Dr. Katie, your radio. There is something for us to learn today in anesthesia and intensive care made easy. The other time I made a video to differentiate between the vein and the artery during jugular venous catheterization. Today we're going to be having the procedure done, all right? Quickly, we're going to learn something. I have prepared the skin because I needed to drape my patient and cover the face from the video. You know, as a doctor, the skin preparation is an aseptic procedure. Aseptic procedure, centromide, dry spirit to prepare the skin. I've done that already and I've draped my patient. Like I said, aseptic procedure. The only thing that is a challenge with ultrasound guided procedure is to learn how to stabilize your hand, because it can actually be shifting here and there. But I've done a lot. Practice make perfect. Your hand will now be perfect, okay? And you won't be swimming here and there. So let's go. After skin preparation, draping, and draping your patient, draping the probe cup, I'm going to be cannulating or catheterizing the internal jugular vein. Internal jugular venous catheterization. We talked about skin preparation and the other things. So ultrasound guided procedure. So come. Look at the ultrasound. Like I was saying, we are going to be cannulating internal jugular vein, okay? Internal jugular venous catheterization. So if you look at this image, you see two vessels, okay? One seems larger, that's the vein. But the reason why you cannot appreciate that size is because my probe will press it. Because the vein is collapsible, like I said in my previous video, go watch it. The vein is collapsible, so, and my probe is on the skin. It will make the vein to collapse. So I'm trying to remove it, and when it's too far, it will be showing a black area. So anytime you see this dark area, it means that my probe is too far away. It's not touching the skin. So I have to touch the skin for you to appreciate the imaging. All right? So where we are going now is this other one that will be collapsible. Just look at it, look at it. It has collapsed. That's the internal jugular vein. That's where we are going to cannulate rather. Internal jugular vein is on top the internal carotid artery. Okay? So the vein is collapsing, but the artery is not. If you look at it again, the vein has a thin wall. Outside the father is larger than the artery. It has a thin wall, but the artery has a thickened wall that looks like a ring if you look at it, and you cannot collapse it. And when you try to collapse it, you will be seeing the pus. Okay, let's try to collapse it. Okay, you see it pulsating now. Are you appreciating the pulse? See it? That's the artery pulsating. It's not collapsible, it's pulsatile. So let's go. After skin preparation, you give your local anesthetic agent. I'm using lidocaine. Without adrenaline, I don't need adrenaline. So I'm not expecting anything to bleed, all right? When you are infiltrating with lidocaine, 2 to 3 minutes is okay. Otherwise, it will not press on your vein. It will distort the anatomy and you won't be able to cannulate very well. Take note that my patient's blood pressure is suboptimal, so that we can still go. We can still cannulate. This position, this procedure is better on held down triangulated, so that there can be venous engulfment and easy cannulation. But for my patient, I didn't bother because ultrasound guided, we've been doing this and we know where to go. So now it's time to infiltrate the skin. So my needle is going there. See my needle? That's my needle. That shiny thing there. That's my needle going. I won't get to the vein because that's not my introducing needle. It's just my infiltration. So you can appreciate, you see, that's my infiltration there spreading out. That's my infiltration spreading out there, spreading out there. Like I told you, if it's too much, you can press the vein. So I won't put too much. 2 minutes should be okay for me. Having infiltrated, you give it a time. Onset of action of lidocaine. I used to have a surgeon that would say, so that you won't be bored, just count in your heart 1 to 60. As the time you counted 1 to 60, that 1 to 2 minutes, the onset of action of lidocaine is already in, is set in. So what you have to do, this is the introducing needle attached to a syringe, a withdrawing syringe. So in here is a parenized saline. Some people won't put a parenized. I can do without a parenized too, but I'll tell you the advantage of this. Especially for people that are that are just learning to put central line. You should put a parenized saline. This is because you can't get it as quick as possible. And if you leave blood in here staying for too long, it can block this syringe. So that at the time you will have a need to reintroduce your needle and aspirate, it has blocked it, you won't be able to aspirate. There are people who are experts that have been doing, like I can do without a perineal saline. But for the purpose of this lecture, I say let me use a perineal saline. All right, what it does for you is that whatever blood that is in here will not be clotted, so it will not block your syringe. So for the first time, if you miss it, for example, you can always extract the blood like this and take saline, and take a perineal saline again and repeat the procedure. But if you leave blood in here while trying to adjust, and do what I have to do, it can clot, and then you'll be looking for entirely new set, because you can't get this needle outside the set, and that would be wasteful. All right, so when that is done, I've infiltrated and buying time for the action of the local anesthetic agent. Don't forget that all this we have been doing, there's KY jelly on the neck. I'm using the right internal jugular vein, and there's KY jelly on the neck so that my imaging can be displayed on the ultrasound. Okay, so local anesthetic agent must have started its work by now, so we will go in. You will use the same pot that your local anesthetic agent went in. All right, and you should be seeing your needle. You can see our vein is barely obvious. It's collapsing because the probe and the local infiltration is exerting pressure on it and closing it up. But we'll still find a way around it. So my needle is coming. The needle, before it penetrates too, that's where the skin is. It will also compress on the vein. But from experience, you should know where exactly, yeah. So look at it, look at it. Look at where we are going. You raise your probe. If you're not seeing it, you can raise your probe a little so that you allow the vein. I shifted the vein away away from the artery so that I can't penetrate the artery, which will not be good. It will result in hemorrhage, bleeding. Okay? So see my needle here, directed to the vein. So that's what you are seeing inside the vein. See something in the vein? Okay? So if you are there, you will aspirate. And if you aspirate, you are there. So you can see blood coming out. If you aspirate, you see blood coming. Okay? Meaning that you are there. That's the vein. So you can still confirm it. Look at this imaging. Look at it. Look at it. You should be able to see your needle. See, my needle is trying to go to the tissue. See my tip of my needle shining in the vessel. If you press it too much, it will be trying to penetrate the wall. So that is shining inside the vessel is the needle. I haven't gotten that. You're already in the vessel and you're aspirating blood. You remove your probe and face the procedure in itself. All right, see, we are able to aspirate. We are still aspirating. Some people will check through the needle. Some will remove. Okay? You remove. And when you remove, you're supposed to be seeing blood like this. To be coming like this. You must stabilize your hand. That's one of the tricks of the technique too. If you don't stabilize your hand, you can miss it. You can see blood coming. Some people prefer to go through that syringe, but that will take a long process. But I can also do that. But for this, you can separate it because there are some syringes that will not have a hole through it for the guard wire. So when you are threading, you thread where the is lateral nipple.
It's going
so
free.
You keep, yes, it's going free. You keep threading the guard wire. You keep threading the guard wire. If it's going freely, then you are still in the vessel, all right? Yeah, beautiful. It should go freely. If it's not going freely, then you are not there. After threading guard wire, you remove your guard wire jacket or the sheet. After removing that, then you remove your needle, the introducing needle. This is sending guard technique. This guard wire is what will get it all through. There's a way to still know whether your guard wire is in the vein, okay? KY jelly, please. See your guard wire, that long straight thing is the guard wire. You can follow it to the vessel. See guard wire straight in the tissue. See guard wire, see guard wire entering the vessel. The vessel is collapsed, okay? See, let me get that straight thing here. This shiny straight. See there. I'll put it, unfreeze the ultrasound. So that's the guard wire, okay? So have you seen your guard wire in the internal jugular vein? You now use a dilator, all right? You also make a skin nip. But me, I don't go first to make a skin nip. I try to use the dilator first and see whether the skin is soft, especially in the elderly, like this also an elderly. So I try to do it first and see whether it will go to the skin, if it's a soft skin. Yes, like it went. If it didn't, I can make a skin nip okay? Let's assume you didn't, okay? You just come to where your guard wire is going in and nip away from the guard wire so that you don't cut the guard wire. And the mouth is away from the guard wire. So you do a skin nip here, huh? A skin nip. After the skin nip, you put the dilator in. You should go freely, yeah. You're going free. Just know that you have dilated. At the time your dilator is coming out, there's going to be bleeding from that vessel. So you have your gauze ready. So you come out and stop it from bleeding. Get your catheter Sedinger technique. It's for nice soap. It's a needle over guard wire and catheter over guard wire. So you thread it through the guard wire. You keep threading until the guard wire is to the tip of the catheter. You cannot push it in because you need to hold it before you thread your catheter in. If you don't hold it and you miss your guard wire, it will be a case of thoracotomy, looking for guard wire. So you now hold your guard wire before you thread in your catheter. Procedure is almost over. Okay? At the time you are threading in your catheter, no blood, no bleeding, because the catheter is covered, it covers the nip now. Then you come out with your guard wire. Taking precautionary measures for hair embolism. After the guard wire is out, you can lock the catheter. Like I said, you flush the 3 ports. We have flushed 1. I was supposed to flush the 2nd and the 3rd respectively. So remember, I didn't charge this catheter. I didn't take away hair. So what I do, I aspirate first. So for the one that is flushed, you just aspirate a little and flush. So I'll see the blood coming, expelling the hair column. So then I'll flush. And make sure you don't finish injecting all your flush because there's hair column, so that you don't push in air to prevent hair embolism, right? You can actually pre-charge your catheter. So you just do which one is comfortable for you, provided you take precautionary measures. So we are flushing the last one. Look at this. Before you open the catheter, you must lock first. Before you open that port, you will lock this port here so that hair will not be entrained. But most times, this position will not allow hair to go because it is at the level below the heart. But if it is above the heart, like in a sitting position, I'll put a central line in a sitting position before. At that point, you take precautionary measures to prevent hair being entrained into the circulation. So for this, I'll connect it first, then open this port and withdraw hair. Withdraw the hair out of the column by withdrawing blood because I did not pre-charge my catheter. So air is out, blood is already here, then I'll flush. Procedure is almost over. What is left for us to do is to secure the catheter. All right? Local infiltration. So in securing the catheter, depending on what the component of your central venous catheter is. Okay, some will come with dressing material, cleaning material, complete set, and even with local anesthetic agents. We drape even, while others will just come with the catheter alone. So depending on what you have, no problem, you can make do with all of them. It's just for you to ask for additional thing in case you didn't follow it. Like if you don't have a sterile drape, you can look for a sterile drape. If it doesn't follow it, you look for a sterile drape. Okay, just look at what you have and source for what you don't have. So this is the catheter. This is the catheter, and this is what you use to secure the catheter. The catheter has a port to secure it, okay? This is to anchor the catheter, and this also to anchor the catheter. This is because this central venous catheter is a very long one. It's about 25 centimeters. So we are going to anchor at 15 centimeters. And at that level, we'll put this there and suture. The procedure is over. We've been able to put an internal jugular venous catheterization, and the procedure well tolerated by the patient. You can look at the catheter. It can be, come see here. It has been anchored. Okay, there's a suture here, there's a suture here, there's a suture here. The reason you have this length out is because it's an extra long central venous catheter. All right, and so we can't put it all. If it is in the right atrium, it will stimulate arrhythmia, it will cause arrhythmia. So we try as much as possible to anchor at the level, depending on the length of the neck of your patient. We stay between 13, 14, and 15. So for this tall man that I have here on bed, I stopped at 14. All right, so we have this length out. It's not a problem. We're going to cover, it's an aseptic procedure, and we're going to cover with a sterile material. So what we'll do now is to clean. I'm going to clean with spirit. Okay. So I clean, then you dry, so that your adhesive material can be well adherent. So it's dry now. I'll take the target then, it's what I have, all right, to dress. But if you look at this, it's wider than the hole that I have, all right? So I'll try to create a wider hole so that my adhesive can have a place to sit on, okay? So I'm still maintaining asepsis so that my adhesive can have a place to sit on. It must be dry, like I said earlier. Sometimes some people can remove it before putting this, but you can still leave it in place so that you don't contaminate the sterile film. Alright? So it's a transparent one, it's called targeting. So see, I'm covering it. Covering it. I haven't covered. So this procedure over, I need to peel off this outer skin. That is just to keep it firm and keep it in place. Off. They take it off the other side. Secure. Beautiful procedure, well tolerated. Thank you for following me. Like I said, life is easier with ultrasound guided central venous catheterization. We're just done with one. Well tolerated.